You are investigating renal cancer here, and there's a big issue about mTOR inhibitors. First of all, could you explain to me why there's an interest in using mTOR inhibitors at all?
So the story of clear cell renal cancer and mTOR inhibitors goes back about 7 years with temsirolimus and everolimus particularly that inhibit the mTOR pathway. We've discovered that actually they predominantly inhibit a specific part of that pathway, which is called TORC1. There's a second component of the pathway, which is called TORC2. And so currently everolimus and temsirolimus are both widely used in renal cancer, everolimus particularly in those individuals who have failed drugs like sunitinib and pazopanib.
Although they are fighting a difficult battle, aren't they?
Yeah, so I think that we know that they delay progression-free survival, and we know that patients who take the drugs do better than patients who don't take the drugs, but they're not resulting in high response rates or cures, for example. So the feeling is that there is a huge scope to potentially improve on this in the future, and one of the ways in which we've tried to do this is because everolimus is only inhibiting the TORC1 part of the pathway, we thought about developing a series of drugs that inhibit TORC1 and TORC2, which may be more efficacious.
And you've got the very drug to do that, haven't you? What did you do in the study?
So in this study we took a drug called AZD2014, and AZD2014 is an mTOR inhibitor. Unlike everolimus that inhibits TORC1, it inhibits TORC1 and TORC2 together. And we did a randomized trial comparing everolimus with 2014, the new drug, to see if the new drug was more efficacious. We tested the drug in individuals who had previously failed sunitinib, which is a standard place where you would normally use everolimus. So really it's a randomized trial exactly where you would normally use everolimus to see if the new drug is more efficacious.
Looking for progression-free survival?
So the primary endpoint of the trial was to delay progression-free survival.
What happened?
So the trial recruited initially 40 patients. The Independent Data Monitoring Committee met, and during its first meeting it discovered that the new drug was less active than everolimus. So in terms of progression-free survival, the patients were progressing quicker on the new drug than on the old drug.
I should ask you about tolerability as well.
So the tolerability is really important because there are 3 or 4 reasons why this may occur. Number 1 is the drug's less active, obviously, but number 2 is it may not be possible to give the drug. In fact, what we discovered was that the AZ2014 was well tolerated. Very few patients were stopping the drug because of tolerability. So the other reason why it probably wasn't working so well was because it may actually be less efficacious, but the reason for that remained unclear.
Well, I was going to ask you about that because intuitively it seems as if it should be more efficacious. What are the candidate mechanisms for that disappointment?
Well, I guess there are 2 key possibilities to this. The first of which is that everolimus is acting much more strongly on TORC1, and TORC1 is more important in clear cell renal cancer than TORC2. And so it may be that yes, the AZ2014 is having activity on both TORC1 and TORC2, but TORC2 may not be as important as we originally thought, and everolimus may have more activity on the more important TORC1.
Could it then be a question of dose?
I think that's a really good question, and I think that there are 2 really important things here. Number 1 is this is a very specific setting, so it doesn't mean that these drugs are not going to work elsewhere in cancer medicine. So that's the first thing. So the drugs are attractive, but not in this specific setting that's being very powerfully driven by VEGF, number 1. And number 2 is there are different dose schedules for this drug. And this drug was given as an oral tablet once a day, oral tablet twice a day. But that can be adjusted, so you could give it once a week, for example, or give it less frequently than that even, and at higher doses, and it may actually be a dosing issue, but we don't know the answer to that question at the moment.
So the interim message, pulling this all together for cancer doctors, might be what?
So I think there are two lessons from this. Number one is independent data monitoring committees play an important part in clinical trials, and we planned to recruit 120 patients. We recruited only 48 in the end, and that's protecting patients, and that's important. And that's number one. And I think the second important issue here is the assumption that we can leapfrog established drugs in renal cancer has proved very hard. We've not done that particularly well in VEGF targeted therapy, and now we're showing actually this second generation of drugs in mTOR is actually less active than the original generation of drugs. So the drug development in renal cancer is becoming challenging.